Started. Okay. Vera, did you want to say anything before I get started?
Well, no, I just want to to start with, just to thank Natalie for putting this information together, because this, I think, is a really important subject for Alliance and for the state, and most importantly for our members, concerned about their health and finance and, ability to be, safely, and more permanently housed. So, I really appreciate everybody taking the time to join us, and Natalie for advocating, for this and giving her time. So, and if there's something else that I really was supposed to say, just let me know.
I think that's perfect. I want to thank all of you all for taking the time to be here today. And as a reminder, please fill out the pre-survey. Vera, you can put it in the chat one more time if there were folks that maybe missed it at the beginning. If y'all can be filling that out as we get started here. So my name is Natalie Rich. I am a tobacco treatment specialist. I am based in Durham County, and I currently serve as the Region 5 Tobacco Prevention Manager, which covers 8 counties in North Carolina, including Durham, but then the other counties are listed here. And really my job is to help support tobacco treatment in Region 5 in these counties, and to help to support policies like tobacco-free and smoke-free policies that are helpful to people who are quitting. So the objectives today are really to talk about the dangers of tobacco use, which I think most folks are pretty familiar with. And then we'll talk about the relationship between tobacco use, mental health, and substance use disorder recovery. We'll talk about how we can support folks to quit using tobacco by referring them to effective resources. And then I'm going to talk about the types of nicotine replacement therapy, also known as NRT, and how we can use that to treat tobacco use in a variety of ways. So at the end, I'll have time for questions, so you all can feel free to type in your questions in the chat, and if we have time at the end, I'll answer them, but I'm also going to leave my contact information, so please feel free to follow up with me if questions happen or questions occur to you throughout the presentation. So I'm pretty sure that everybody is familiar with the fact that tobacco use is not good for your health. But sometimes I think, especially in this current environment, we forget that the toll that tobacco use has. So in North Carolina, 1 in 5 deaths are due to tobacco use, and smoking causes more deaths than alcohol, AIDS, homicides, suicides, car crashes, and illegal drugs combined. And then it's also important to remember that even though tobacco use isn't kind of an immediate killer like some other drugs that we might encounter that our patients or our clients are using, tobacco use does cause a lot of disability. So for every tobacco-related death, there are 30 people who are living sick or disabled from tobacco use. Smokers have a 30 to 40% higher risk of diabetes than non-smokers. This is something that I didn't know until I started working in this field. And I think most folks know about the link between smoking and lung cancer, but smoking actually causes cancer in every single organ in the body. So even things like stomach cancer, urinary cancer, all of those things are linked to smoking. There's other health issues like heart disease, stroke, gum disease, vision loss, diabetes, I already mentioned, rheumatoid arthritis. All of these are connected to smoking. And then there's some other non-fatal things like erectile dysfunction or fertility issues, birth defects, preterm birth and low birth weight, and then some of the cosmetic things like yellow teeth, dry skin and hair, and wrinkles that are connected to smoking and tobacco use. And sometimes I think that we forget that these can have an influence on a person's motivation to quit or stay quit or to reduce their tobacco use. Secondhand smoke is also extremely deadly. And this is something that I wasn't really aware of until I got into this field either, is that there are 34,000 heart disease deaths, 7,300 lung cancer deaths every single year among people who've never smoked in their life. And this is due to their exposure to secondhand smoke, which is a huge toll. And then I think the folks that are most vulnerable to secondhand smoke are children. And I know a lot of us can probably relate to this. Like for me in my own life, I have asthma as a result of my exposure to secondhand smoke as a child. Secondhand smoke is a leading cause of asthma in children, ear infections, bronchitis, and is also related to sudden infant death syndrome. And so oftentimes for folks who may not have a desire to quit for themselves, just being aware of the level to which secondhand smoke could be harming the folks in their lives, at the very least, helping them to create a goal not to be smoking indoors anymore. So among the general population, tobacco use rates have gone down a lot over the last few decades, and they're right around 20% nationally. However, when we work with the behavioral health population, and you all probably know this, it's a much higher rate of tobacco use, so it can range from 32 to 98% depending on the diagnosis, and some diagnoses are more likely to have high rates of tobacco use. So tobacco use has a huge toll on our society, but this chart kind of gives a visual of that. So when you look at the bar on the right-hand side, that is all the deaths every year for obesity, drug overdose, suicide, motor vehicle crashes, alcohol, homicide, and HIV/AIDS. And when you add all that up together on that right-hand bar, you get 288,000 deaths per year. Well, tobacco causes 480,000 deaths per year. And so it's still causing a tremendous amount of disease and death among people, many more than a lot of other issues that get a lot more attention. And then if you look at the bar with the star on it, on that tobacco bar in the graph, that shows you the number of people with a behavioral health condition who are dying from a tobacco-related illness. And it's way overrepresented. And so this is where we kind of see the effects of those higher use rates among people with behavioral health conditions. So in the US, folks with a behavioral health condition who use tobacco lose an average of 25 years of their life. That is a huge, huge amount of time that is lost. And more than half of those in treatment for substance use disorders right now will actually not die from their substance. They will die from a tobacco-related illness. So just think about that for a minute. Half the folks that are currently in treatment for their substance use disorder will ultimately end up dying from tobacco and not from their substance use. People with behavioral health conditions who smoke are 4 times more likely to die prematurely than those who do not smoke. And so when you take all of this together, it really paints a picture of how tobacco is ultimately unjustly impacting the behavioral health community because of these higher use rates. And even though sometimes I think we like to make it a priority to address substance use and mental health conditions, and then kind of put tobacco to the side, ultimately that ends up being the thing that could be the biggest threat to our clients. Okay, so this is, I kept this in here and I don't know if you all want to participate in the chat. This is a true, false, just to kind of gauge where you all are at on this. Nicotine relieves stress by relaxing the muscles and lowering blood pressure. Is this a true or false statement? If you want to enter that in the chat, true or false? Nicotine relieves stress by relaxing muscles and lowering blood pressure. Okay, I got a lot of falses. Okay. A lot of falses. Good job. So you all know this. This is absolutely false. Nicotine actually raises your blood pressure, causes your muscles to tense up. And the smoker actually experiences stress relief because they've satisfied their craving for a cigarette and eased their withdrawal. And so looking at this cycle of nicotine withdrawal, smoking a cigarette, and then you relieve your withdrawal, and then ultimately after a while your nicotine level is going to drop, you're going to feel withdrawal. Well, withdrawal feels a lot like stress. And so nicotine addiction actually creates stress from the constant cycle of withdrawal. And that means that quitting improves your overall mental health. So ultimately, quitting smoking overall decreases your stress because you are now free from this withdrawal cycle. So I want to talk a little bit about nicotine because this is the stuff that actually addicts people. So nicotine is the chemical in a tobacco product that makes it addictive, but it's not necessarily what causes illness and death. Nicotine does raise blood pressure and it can constrict your arteries, but ultimately it's all the other chemicals in the tobacco product, in the smoke, that end up causing lung cancer, heart disease, and all those other things that I mentioned at the beginning of the presentation. So I want to talk a little bit about why nicotine is so why there's so much nicotine in tobacco products and why tobacco products in their current state are so dangerous. So if you are from North Carolina or from the South, you know that tobacco has been around here for a long time. It's actually native to the Americas as a crop, and it's still among North Carolina's biggest cash crops. And living in North Carolina, living in Durham, we know that this whole place has been built on tobacco money, the tobacco industry. And long before the current tobacco industry, Native Americans have used tobacco for thousands of years as a medicine, right? So how do we reconcile this with the amount of death and destruction that we see tobacco in its current state? Well, we know now that today's tobacco is very different from the naturally occurring tobacco leaf that was used for thousands of years by Native Americans. There is 2 times the amount of nicotine in current tobacco. And that is largely due to genetic engineering by tobacco companies to maximize the amount of tobacco, or to maximize the amount of nicotine in the tobacco leaf, because it makes it so addictive, because it creates a product that makes people come back for more and more. So why is tobacco so deadly now? So I mentioned the idea that it's not the nicotine that really does the damage to our bodies. It's all of these other compounds. So it's things like ammonia, things like menthol, and menthol is actually added to all cigarettes, not just cigarettes that are labeled menthol. Things like nitrosamines. All of these chemicals are added to maximize the absorption of the nicotine and to make the product as addictive as possible. But they're also these additives that make it so damaging to our bodies. Okay, so here's another true false, and I want you all to weigh in on this one. True or false, quitting smoking can trigger a relapse into drug and alcohol use. Is that true or false? Quitting smoking can trigger a relapse into drug and alcohol use. True or false? Okay, we got a couple of truths, got some falses, got some truths. Okay, so we got a good mix here. So this is something that I would have said true when I was working with folks with substance use disorder, but I now know it to be false. Quitting smoking actually increases the chances that a person will stay clean and sober, and it improves a person's overall mood and quality of life. And this includes folks who are struggling with substance use disorder. And so I want to delve into this a little bit, because for me, I was like, make it make sense, like I was not a believer when I first heard about this. So there have been multiple studies that have showed that continuing to smoke or starting to smoke can increase a person's chances of returning to substance use after treatment, and that smoking cessation can increase the likelihood of long-term abstinence. In this particular study, it was by about 25%. So when you take actually the whole body of research that's been done on this and put it together, the clear takeaway is that quitting smoking actually enhances a person's recovery. It enhances the chances that they're going to stay in recovery. Well, why is that? So why is smoking associated with relapse, and why is quitting associated with long-term recovery? Well, the reality is that when you think about something like smoking and substance use, oftentimes they're linked. You can't have one without the other. So what goes better with a cigarette than a person's drug of choice? It looks like we have some drawing happening on the screen, and I'm not really sure how to get rid of that. So we call this classical conditioning in psychology, where we have two things that are repeatedly paired together. You add the rewarding feeling of nicotine that you get from using that nicotine withdrawal if you are addicted, and then you have a situation where when you have one, you got to have the other. And in recovery, we call this people, places, and things, right? So ultimately, smoking is a thing that is associated with a person's use, right? And so every time you pick up a cigarette and you smoke it, even though you have abstained from your drug of choice, somewhere in your brain, that addiction cycle is still going, and there's a part of that person's brain that's saying, hey, I remember what goes really well with this cigarette is my drug of choice or using. And so that is why quitting smoking can help set a person up for staying in long-term recovery. So I really want to figure out how to fix the drawings that are on here. Does anybody, if anybody knows how to do that, then please let me know.
I do not know, and I don't know who's doing it either. So I don't. Yeah.
All right. Well, then
You can go to where on the bottom of your screen, you should see where it says like annotations or something like that, and open up that box. And there's an eraser, and you can click that eraser and it should get rid of it.
Okay. Hold on.
Picture of a little eraser.
Oh, okay. Annotate. Eraser. All right.
Just click it. There you
I
go.
got it. Okay. Thank you so much.
You're welcome.
From
one Natalie to another.
Oh, is that another Natalie? Oh, I'm so excited. Thank you. I do appreciate that so much. Okay. So I'm going to X out of this. Wow, you learn something new every day in Zoom, I'm telling you. All right, so we are back online here, y'all. Okay, so to sum up this, we know from the research that quitting smoking is associated with decreased depression, decreased anxiety, fewer hospitalizations, decreased psychotic symptoms, improved quality of life. And then improved chances of staying in recovery from substance use disorder. So another question that I know that I've had and I get a lot, what about schizophrenia? So remember at the beginning when I said that the range of tobacco use can be 32 to 98% depending on diagnosis. That 98% is that is reflective of folks with schizophrenia, because that's where we tend to see the highest rates of tobacco use. And in a meta-analysis, so this is a meta-analysis is where you look at all the studies that pertain to a particular topic, and then you draw a conclusion based on all of their results. So it's a much bigger outcome than just one study, right? Because you're looking at all the studies and all the research. So a meta-analysis said that there's no published evidence to support the hypothesis that quitting smoking is harmful to the mental health of people with schizophrenia. So smoking cessation does not appear to place smokers at risk of having worsening of their symptoms, and it may even improve their mood. And so where does this idea come from? Because I know I've had this idea that that folks with schizophrenia kind of needed that nicotine or needed smoking to help them regulate. Well, as it turns out, the tobacco companies themselves have funded research to support this idea that tobacco is needed as like a self-medicating tool, particularly for folks with schizophrenia. Overall, we know that life expectancy is 14 and a half years lower for people with schizophrenia. And this is largely attributable to their tobacco use. And tobacco companies are also really good at promoting smoking in psychiatric settings. And they have folks whose job it is to block smoking bans in these settings because they want to make sure that their products get into the hands of folks that are the most vulnerable to nicotine addiction. And people with schizophrenia are among the most vulnerable. And so tobacco companies are really good at making sure that we believe that their products are helpful to our clients, and really that they're not. Okay, so this is another little quiz question. You all can feel free to put the letter in the chat of the one that you think is the correct answer. Which of the following is safer than cigarettes? Is it dip or chewing tobacco, cigars, cigarillos, nicotine patches, e-cigarettes, hookah, or all of the above? Which one of these do you all think is safer than cigarettes? Okay, none, okay. C, I got a lot of C's. C, good job. All right, y'all are rocking this out. So I did want to touch a little bit on some other tobacco products, but I wanted to make the point, and we're going to talk about this at the in a little bit. Nicotine patches are really the only product on this list that are deemed safer than traditional cigarettes. Little cigars and cigarillos. Oftentimes folks use these products because they're cheaper than buying a pack of cigarettes. You're quote not inhaling. Sometimes it's more of a social addiction. But the reality is that this is no different from smoking a cigarette, whether or not you think you're inhaling. It is the same tobacco with the same chemicals that would be inhaled from a traditional cigarette. And it causes all the same health impacts that we see from smoking cigarettes. The same with hookah. I know this is a trend among young people. So hookah is a heat, not burn product. And so oftentimes folks think that it is safer because you're not technically inhaling smoke. And then you have the water pipe that's quote filtering out the chemicals. Ultimately, that's not true. And a hookah session can be equivalent to smoking 100 to 200 cigarettes in one sitting. When you look at the impact that it has on your lungs. There's also research that shows that hookah use causes the same respiratory impacts that cigarettes do. So lung cancer, respiratory illness, low birth weight, and respiratory problems among infants. And then we have electronic cigarettes, which have sort of exploded in the market just in the last few years. And so they come in all different shapes and sizes, and a lot of people feel like they're safer than cigarettes, and a lot of people use them as a cessation tool or a cessation device to help them get off cigarettes. So I want to kind of break this down a little bit. Electronic cigarettes, no matter what they look like, they all kind of work the same way. So they have a cartridge that holds the liquid nicotine with flavors and other chemicals. There is an atomizer. So that is something that actually heats up the solution. And oftentimes it's heated using a metal coil. And then there is a battery or a power source. And so this is kind of the construction, no matter what the actual e-cigarette looks like, all of them kind of boil down to this same type of construction. So what's actually in this aerosol or e-liquid? The important takeaway here is that it's not water vapor. Most e-liquids contain nicotine. They contain fine and ultrafine particles that are oftentimes similar to conventional cigarettes. There's also some tobacco-specific carcinogens and toxins that are often included in the e-liquid as well. There's a chemical called propylene glycol. This is a chemical that helps the liquid vaporize once it's heated. Propylene glycol has been associated with respiratory disease and illness. Propylene oxide is another chemical used to help vaporize the liquid. And then heavy metals. So the reason why you get heavy metals in the aerosol is because the heating coil, which is usually made out of metal, when it's heated to a really high temperature, little bits of that metal could flake off and it gets kind of put into the aerosol, and then the user ends up inhaling these little flecks of heavy metals off that heating coil. So there's a lot of flavorings and ingredients like the propylene glycol that I mentioned, like nicotine, liquid. Are these ingredients FDA approved, right? All the ingredients that we put into e-cigarettes, are they FDA approved? What do you all think? You can just put a quick yes or no in the chat. Are they approved by the FDA? All the flavors, all the nicotine, the propylene glycol. Okay, everybody's saying no. Are they approved by the FDA? Guess what, y'all? Everything that you have in an e-cigarette juice is approved by the FDA. Now, this might seem a little bit strange to you, right? But the reality is that all the flavorings, the propylene glycol, everything that's put into an e-liquid is FDA approved as a food additive, right? All of the flavors, all of these things are approved to be put into foods, and they're seen as safe as a food additive. But the reality is that lungs are not stomachs. And so putting something in food is very different from actually heating it up and inhaling it. And so if you all remember a while back, there was this thing called popcorn lung that was observed in factory workers who were working in a factory that produced microwave popcorn. And what they found out was this chemical called diacetyl, which is perfectly safe to eat in microwave popcorn, when you heat it up and inhale it, causes irreversible damage to your lungs. And so that's what we see now with a lot of the e-cigarette flavors. Diacetyl actually was one of the flavors in e-cigarettes. But a lot of the flavors, yes, they are absolutely safe to eat, absolutely safe to be put in your food. But when you heat them up and put them in your lungs, it causes a tremendous amount of damage. So while they are FDA approved, it's important to remember what they're approved for. E-cigarettes can deliver a lot more nicotine than conventional cigarettes, and that has to do with the way that the nicotine is chemically formulated. So what we often see, and the reason why I don't recommend using e-cigarettes as a cessation tool, is because getting off of e-cigarettes ultimately ends up being harder than getting off traditional cigarettes, because the levels of nicotine in e-cigarettes tends to be so much higher. Okay, so now I want to transition from talking about tobacco, different types of tobacco and the dangers of that, and talking about how we can treat tobacco use disorder in the clients that we work with. So it's important to remember that tobacco use disorder is a chronic and relapsing condition, just like other medical conditions and other substance use disorders. Most people try to quit many times before they become tobacco free in the long term. This was true for me as a former smoker, and it's true for pretty much anybody that I've worked with. Very few people are going to quit on the first or second or even third attempt. It's going to take quite a few attempts. And really, a combination of counseling and medication is what sets people up for success. It can actually double the quit rate, particularly adding medications. And when I say medications, I'm including NRT in that. So one of the things that people often assume is that people have to be ready to quit smoking. But the reality is that very few of our clients are going to be like, yeah, I'm ready to quit. And the truth is, we don't wait to offer treatment to folks who have other chronic conditions. We don't wait for them to be like, yeah, I'm ready. So when you think about diabetes or HIV, you don't wait until a client is ready before we start that conversation about what treatment looks like, right? And so I would encourage you all to start thinking of tobacco in that way, of just having that conversation with our clients, and not waiting until they're ready to hear it, because oftentimes folks are never feel like they're ready. So one thing too is that I've learned, and I was definitely guilty of this, is having this bias about addressing tobacco use. We know that people with behavioral health conditions, and even us as behavioral health providers, have been exposed to tobacco industry marketing and influence on society. And oftentimes what that means is that we have this bias that like smoking isn't that bad, tobacco use is not something that we really need to be talking to folks about when they have other bigger, larger issues that they're dealing with. And so a lot of times this can sound like, oh, well, I'm working with this client who really needs to quit drinking first, and then maybe we'll deal with smoking. Or like smoking is the least of her problems, like she needs to find a place to live. Or even telling clients, and I know I used to do this too, like, wow, you're getting upset. Maybe you should just take a smoke break and calm down and like, just take a moment. And ultimately, what we don't realize by doing this is that we can undermine our clients who maybe are interested in quitting. And even if they don't feel ready, maybe they have a desire to quit. 70% of smokers with a behavioral health diagnosis actually want to quit. And they're often as motivated as folks without a behavioral health diagnosis. And ultimately, sometimes it's us that gets in the way because we assume for our clients that tobacco isn't a priority for them. And so we don't even bring it into the conversation. We don't even put it on the table. And sometimes, that, again, it undercuts our clients. It's not person-centered. We are taking control of making that decision for them, and that's not fair. So we have in the tobacco use treatment world, something called the 5 A's. And these are a series of steps that we go through with clients to help them on assessing and addressing their tobacco use. So I want to go through each one of these with you all. And the first thing that we want to do is make sure that we ask each and every client about their tobacco use. And I'm pretty sure that most of you all are probably already doing this because it's typically part of any intake process. And I like to encourage folks to keep that question simple and keep it broad. Do you use any tobacco products? Rather than asking something like, do you smoke? Because oftentimes folks may not identify as a smoker, or especially if they're using maybe not every day, or maybe they smoke when they can. So do you use any tobacco products? And sometimes I like to include examples that are tailored to the population that I'm talking to so that I can make sure that I'm getting a correct answer to that question. And then the next step is really to advise the client. And this should be a really clear, strong, personalized statement advising them to quit. And sometimes I think we skip this because we don't want them to feel bad, or maybe, again, we're making that decision for them that this isn't an important thing, but simply stating that quitting tobacco is one of the best things that you could do for your health. Or maybe introducing the idea that quitting smoking could support them in their recovery. And ultimately, when they're in a supportive environment, like a treatment center or a shelter or a place where they're going to be getting a higher level of care, that is one of the best places to attempt quitting tobacco use, right? Because they're going to be getting more attention and more resources and therapy than they would if they weren't in that situation. And so being able to give a really clear statement advising your client about quitting and what it could do for them in their recovery, or what it could do for them in improving their quality of life. And then you all know how to use motivational interviewing, use skills to explore their ambivalence, or maybe reflect, change talk, all of those skills that we use to talk to clients about their behavioral health condition or their substance use disorder. We can use those skills when talking about tobacco as well. And then just some questions to help assess smoking behavior. Asking permission. This is always helpful. May I ask you a few questions about your smoking? How important is quitting to you? How confident are you that you can quit? Again, using some of the same tools that we would in conversations around other substance use or around their behavioral health. There is a handout, and I believe I included this in the handouts that we'll email out to you. This can be a great tool to help a client just really reflect on their smoking. What do they like about it? What makes it hard for them to quit? What would be good about being tobacco free? And again, just presenting this as a way, as a reflection tool for them, right? Without maybe putting that pressure on them, but just allowing them to really reflect on their tobacco use the way that they would reflect on their other substance use or reflect on other behaviors that they have. And then step would really be assisting them in setting a goal and making a plan. So sometimes this goal may be directed towards quitting, but sometimes it may be taking a step towards reducing their tobacco use or having a goal where they use tobacco in a way that's not going to jeopardize their housing, for example, or jeopardize the other people in their lives by making a goal around smoking outside, or making a goal to call the quit line. We'll talk about what that is as well. And then helping them to make a plan for how they're going to achieve that goal around their tobacco use. And oftentimes what can help with this is figuring out what's worked for them in the past and what hasn't. And so for the client who is willing to quit or willing to make an attempt to quit, working with them to set a quit date, encouraging them to tell family, friends, and coworkers so that they can get some social support, helping them to anticipate the challenges to quitting, helping them to remove tobacco products from their environment, and then making sure that they get set up with success by getting them some nicotine replacement therapy and referring them to the quit line, which I'll talk about. And then remember that the majority of relapse occurs within the first 2 weeks after quitting smoking or quitting a tobacco product. And so it's important to really check in if you know that a client has set a quit date and is really serious about quitting, making sure that you are able to check in and follow up with that client within that 1 week period after their quit date, because that's when they're going to be the most vulnerable. So what if the client's not ready to quit? And this is going to happen for a lot of folks in my experience, of being afraid to sort of quit right now, but wanting to maybe quit eventually. And so consider asking the client, do you ever plan on quitting? And then if they say yes to that, then you can follow up with something like, what might be the benefits of quitting now instead of later? And so most people will agree that there's really no perfect time to quit, and that there are ultimately benefits to quitting sooner rather than later. And then another question that you could follow up with would be, what would have to change for you to decide to quit sooner? And this will ultimately help to identify the barriers that they face in this moment to quitting their tobacco use. So for clients who are not ready to quit, you can work with them and continue that conversation by addressing what we call the 5 R's. And so relevance, so helping the client to figure out, what about their situation, or what are some relevant reasons for them to quit. The risks, so helping them identify negative outcomes if they continue to use tobacco. The rewards, helping them to figure out what could be some benefits to quitting. The roadblocks, so what are the obstacles for them quitting and how can they possibly overcome them? And then the last R is about repetition. And so this is something that I find really challenging, but I know that it really works, because we never know when a client is going to have that aha moment. And sometimes it can be tempting to say like, oh, well, I talked about tobacco last time, I don't want to bring it up again. But it's really about that repetition, because you never know, again, when you might have that conversation or open up that conversation with that client And just on that day, something has happened recently that has pushed them into that mind space of like, actually, I really do want to quit, or I really do want to talk about how I can tackle this. Okay, so now I want to move into talking specifically about nicotine replacement therapy and how you all can use this as a tool to maximize your clients' chances of quitting, or at the very least meeting their own goals around their tobacco use. And then also how you can maximize a client's access to NRT. So first I want to talk about what NRT is. NRT is nicotine replacement therapy. It comes in patches and gum and lozenges. It is over the counter, and it's over the counter medication for a reason. It is extremely safe. It's important to remember that you can smoke while using the patch, the gum, or the lozenge. A lot of clients and a lot of folks are nervous about this. At the end of the day, it is safe, even if the client continues to smoke. The nicotine patch and the gum plus the lozenge. So if you use a nicotine patch and a gum and lozenge together, you're still not going to get the full amount of nicotine that a client receives by smoking cigarettes or using tobacco. So that's why ultimately these products are so safe, is that they're, even if they're using the nicotine patch and the gum plus all of that together, they're still going to be receiving more nicotine when they smoke a cigarette than they would from these products. Nicotine overdose is very rare. And the symptoms of overdose are nausea and lightheadedness. Nicotine overdose is also very unpleasant. And so the risk of actually having a client, trying to, it's non-existent that a person would be hoarding nicotine and in some ways getting a pleasurable effect from using a lot of it, because it's an unpleasant experience if you have too much. There's no evidence that the use of smoking cessation therapies increase the risk of serious cardiovascular events. So this is another concern, is that folks feel like if they use the patch, they're going to increase the risk of having a heart attack. That's not true. The truth is that smoking increases the risk that you're going to have a heart attack. And even if a client has a heart attack or a cardiac event while using NRT, ultimately the cause of that was their many years of smoking that predated them putting that patch on. Sometimes folks might be concerned that they're taking too many medications. Quitting smoking can actually help a client reduce the number of medications that they have to take, or reduce the dosages of medications. And so that's something to keep in mind. Also, the side effects from smoking tend to be much worse than the side effects of nicotine replacement therapy. So I actually have a handout with these charts on it. This is a nicotine replacement therapy dosing guide. This is for the patch. So if you don't know, the patch comes in 3 different strengths. There's a 7 milligram, a 14 milligram, and a 21 milligram. So the dosing works by assessing how much the client smokes. So if a client smokes less than 10 cigarettes a day, a 14 milligram patch should work for them. If they are smoking 11 to 20 cigarettes per day, then a 21 milligram patch would be a good place to start. And then if a client is smoking more than 20 cigarettes a day, then you're going to want to look at having multiple patches. So you can go all the way up to 42 milligrams. That's 2 21 milligram patches per day. It's important to remember to replace the patch every single day. One patch is only for a 24-hour period. And then for the instructions to give for the nicotine patch, you want to make sure that you put a new one on first thing in the morning. You want to put it, if possible, on a hairless part of the upper body, and then also move the patch location. And then you want to make sure that you leave it on all day. And then even if you smoke a cigarette, don't take the patch off, keep it on. And if you feel nauseous or lightheaded, then the strength of the patch may be too strong. And so in that case, you might want to take it off and then get a different strength. This is the dosing guide for the gum and the lozenge. And honestly, this chart is like a little bit, more complicated than it needs to be. So I want to kind of just break it down for you all. The gum comes in 2 strengths. There's a 2 milligram strength and a 4 milligram strength. I typically what I do is if a client is less than a pack a day smoker, then I typically give them a 2 milligram gum. If they are around a pack or more, I give them a 4 milligram to try out. It is absolutely safe and recommended that a client uses a patch throughout the day and then uses gum whenever they crave a cigarette. Using those 2 things together is absolutely safe and is actually recommended. I just tell the client to pop in a piece of gum whenever they feel a really strong urge to have a cigarette. So with the gum, you want to make sure that you don't chew it like regular chewing gum. You just chew it until you can taste that peppery taste. And then you want to park it between your cheek and your gum. And then keep in mind that it lasts about 30 minutes. Once you can't taste that peppery taste anymore, then all the nicotine is already in your system. And then the nicotine lozenge, also want to park that between the cheek and the gum, and then it will absorb into your system through your gums. So talking with clients about counseling and medications, really the medications are to help ease the withdrawal symptoms, right? So that you can have the energy to focus on making some of the behavioral changes and reducing your triggers. And then the counseling or coaching is really to help you get in touch with your motivations to quit, and to help structure your behavior so that you're more likely to be successful. So I want to talk about the Quit Line, since that is the #1 resource that I refer clients to. The Quit Line is a free telephone counseling service. There's also a new texting program that was just launched. And you can access the Quit Line by going online or calling 1-800-QUIT-NOW. And so the Quit Line, like I said, it's evidence-based. It's a telephone service. The Quit coaches are very highly trained. The Quit Line is available to all North Carolina residents. So that's important to remember, is that you have to be calling from a North Carolina area code in order to access the North Carolina Quit Line. It is accessible 24 hours a day, 7 days a week. And there are Spanish coaches available as well. And the cool thing about the Quit Line is that it can vastly increase a client's chances of being successful in quitting. So if you look at this chart and you look at the very bottom, Quit Line counseling plus nicotine replacement therapy, that the quit rates are 39% and 47%, as compared to 10% and 27 or 10% with just the physician advice alone. Right now, the Quit Line has a behavioral health protocol. I would imagine that most of your clients, if not all, would qualify for this. The behavioral health protocol includes 7 calls with the client, and that Quit coach in the behavioral health protocol is specially trained to work with folks that have substance use disorder or have a mental health issue. They can qualify for 12 weeks of nicotine replacement sent to them. And then in order to qualify for the behavioral health protocol, and this is also included in the handouts that we will send out to you all, the client must answer yes to question 1 and question 2 listed here. So question 1, do you currently have a mental health condition? And do you think that that mental health condition might interfere with your ability to quit? All clients who call the Quit Line will be asked these questions. If a client answers yes to both of these questions, they will automatically be enrolled in the behavioral health protocol. So when a client calls the Quit Line, they will qualify for, if they set a quit date, they will qualify for the 12 weeks of NRT with the behavioral health protocol. And then if the client has Medicaid, they can get a prescription signed by the Quit Line medical director that enables them to get 12 more weeks of nicotine replacement therapy. And that would be sent to their pharmacy. So they would have to pick up the NRT from their pharmacy. So when you are working with a client and they've called the quit line, and you want to help them maximize their access to NRT, make sure that you let them know that they should receive a packet of papers when they get their initial quit line or their initial NRT sent to them from the quit line. In that packet of papers that they get, that's how they can get the standing order with the additional 12 weeks of NRT. So this is really about helping the client maximize their NRT access, right? So you want to reframe it as a way to help them treat their nicotine withdrawal, to meet their goals around their tobacco treatment. Remember that Medicaid clients can also request a prescription from their doctor as well to be sent to a pharmacy, and they can get nicotine replacement therapy that way. And then, of course, if they set a quit date when they call the quit line, then they can get their nicotine replacement sent to them at their address that they're staying. So here is a chart that I've set up because I'm working currently with Alliance to help different sites get set up with nicotine replacement that they can give to clients as a 2-week startup kit, right? And so the idea would be that you all would get a 2-week startup kit to give to clients when they first arrive. During that 2 weeks, you can work with the client to call the quit line. They get their 12 weeks of NRT sent to them from the quit line. And then in addition to that, they can get a prescription from the quit line for 12 more weeks. And then if they need more even after that, they can work with their doctor to get a prescription sent to their pharmacy for additional NRT as well. Keeping in mind that these last two things are only available for Medicaid clients currently. So when you call the quit line, it's helpful if you do it with the client, and then you can kind of prepare them for the process. And there's also a text option for clients who want to enroll in the TEPS program. They can text ready to 200-400. And then the last thing that I wanted to plug was the benefits of having a tobacco-free policy. The reason why this is so important is that I work with a lot of folks who either restarted smoking or started smoking because they were in a behavioral health facility or a substance use treatment program. And they were around it so much that they either picked it back up again or picked it up for the first time. So oftentimes we don't really set our clients up for success because of the way that tobacco use is so ingrained into the culture in a lot of behavioral health facilities. And this is why tobacco-free policies in some ways are a way of supporting clients in not only in their journey to quit smoking, but also in their overall recovery for all the reasons that we talked about at the beginning. And then here is my contact information. We have a couple of minutes left over. I covered a lot of information, you all. So if you have any questions, I do have a list of handouts that I will be emailing out so that you all will have that. I can also email out this presentation. But if there are any questions, then I'm happy to take them now.
Yeah. Hey, Natalie, this is Ed. Just a quick question. So I think what I heard too is the first step that we should probably take, besides the conversation, the 5 A's, is to get people to that quit line as quickly as we can, as expeditiously as we can, to start the process so we have a professional talking to them. Is that correct?
Yeah, absolutely. I think the earlier that you can get a client set up with the quit line, the better. And I think just reinforcing with the client that the positive benefits that they could get from connecting with a quit coach, and having that access to NRT to help support them.
I had a quick question. I'm actually calling in over the phone. I guess you guys can hear me.
Yes.
Okay, so you were saying that something about the 2-week trial to give to our clients. How are we able to access that? And if I'm calling in over the phone, will you guys still email me the other information you were talking about or discussing?
Yeah, that's a great question. So I think I'm emailing the packet of handouts that will hopefully get emailed out to anybody who's registered. So
And they've gone out already, but if you didn't
Okay.
receive them, please let me know.
great.
This is Larissa, who you would have registered through.
Okay,
And
so I
then-
did register before. I'm just,
Awesome.
Okay, so you should receive an email with the handouts. Actually, it just went out.
okay. Thank you.
And then for the 2-week supply, so that's something that I'm currently working with Alliance on right now, because I do have a supply of NRT, and I would like to make sure that the organizations in the community that could benefit from having some NRT that's working on right now.
Okay.
So we have, what we're doing is we're putting NRT at our bridge housing program in Durham. So Natalie's actually out of Durham, so you have to be in Durham County to receive the NRT at this moment. So our plan is that we would have it there for our participants. But if you're in Durham County and you're a provider, that would be a conversation between you and Natalie.
Thank you.
And then this is Vera. So just a reminder, NRT is just a phone call away, with the quit line also. So even if that you can't hand somebody a 2-week supply, they can still have access to it, pretty quickly. And ideally, I would love to expand, what we're doing with Natalie. We'll see how it goes, and maybe we can make a case, for Alliance, because it is a significant factor in getting people housed and keeping them housed. And, it may overall, be a lot more cost effective for us. So.
And I will say, I really do appreciate what you said, Natalie, about having a policy of no smoking policy. Our crisis centers that are run by Recovery Innovations, they are smoke free. So as soon as somebody goes in there and they're in crisis, they're giving them the patch at the door. And so, so many times the providers may feel like it's counterintuitive that they're getting this patch when they're in crisis, but it's proven to be effective. So thank you.
Yeah, I just saw a question in the chat. That's a really great question about working with older smokers or folks who already have symptoms. So patients who are saying something like, what does it matter? I already have shortness of breath, or I already have COPD. And I work with clients for whom this is the case all the time. And the reality is that there may be some irreversible damage that clients have from their smoking at this point. However, ultimately, and I've seen this happen many times, if a person is able to quit smoking, that could ultimately, I won't say could, it will ultimately delay, even if they already have a diagnosis of COPD or even lung cancer, it will ultimately delay the progression of their disease. And it could delay it for a really long time. And there could be some lung repair that happens during that time as well. And so I always tell people that it's never too late. And it could be the difference. I mean, if you're talking about something like lung cancer or COPD, I've known somebody who had stage 4 lung cancer and, very much thought, what's the point? And the doctor had given her, I think, 2 to 4 months. She quit smoking and she lived for 4 years with that diagnosis. And so, it can really buy them some time of, of life that is enjoyable and has more quality of life as well. I hope I answered that question.
And I would second that, Natalie. I know even with people that are really like end stage COPD, they still say, they still recommend they stop smoking because they do see like an improvement in lung function. It won't make their COPD go away clearly, but having carbon monoxide in your system is never helpful. So.
Hi guys, this is Vicky. I just wanted to jump in and add too, from a nursing perspective, even you see very drastic benefits for quitting smoking in things like reducing your risk for heart attack. I mean, that really changes things within a year. I forgot what the stats are, but it dramatically reduces that. It also with diabetes, it helps, when you're not smoking, you're healing better. It helps with your circulation. It's things that are involved with infections, with pneumonia and bronchitis. When you're quitting that smoking and those irritants, those symptoms are vastly improved. So it has a health effect all the way through. And for our folks that have some significant medical issues, especially for the comorbids, quitting smoking, it helps with the way the medicine's processed in the body. So it's, your medicines are more effective. So there's a lot of benefits. And like Natalie said, it's never too late.
So I know that we're at time, you all. I hope that this was helpful for you, and I want to encourage you all to follow up with me with any questions. We can include my contact information in the follow-up email. And then I also just want to say that when you receive your follow-up email, there will be a post survey. If you all could definitely fill that out. It will only be a couple of questions, just like the pre-survey. And then again, feel free to follow up with me with any more questions or comments or feedback. And then if you are interested in exploring opportunities for getting NRT for your clients, or if you want to explore opportunities in creating a tobacco-free policy or smoke-free policy at your workplace, or just any of those things, please feel free to follow up with me on that.
All right. So
thank you all so much.
Thank you so much for everybody. We'll be recording it. It's recorded and we'll be putting it out on our on Alliance website. So thank you so much. Thank you, Natalie.
Thank you.
Thanks,
Thank
everyone.
you.
Great presentation.
Thank you.
Again.
Yeah, awesome job, Natalie.